background about me and my perspective, because I think it helps to understand the context of how what healthcare analytics is in my world and kind of how I see it, because it is kind of, it can be a lot of things can be considered healthcare analytics, and I am a director of analytics at Northwestern Medicine, so my perspective is really from the healthcare provider perspective, and I've been in healthcare for 9 years now, done all kinds of things within that scope. Played a lot of different roles as well. When I got started, I was more a developer, doing kind of focusing on complex logic, trailers and SQL, and a lot of data architecture, still my favorite thing to do. But these days, I spend most of my time in meetings and doing other leadership fun stuff, but it is still actually a lot of fun. We work with a lot of smart people and we're doing a lot of cool things. So it's actually almost, the reward you get from building something with your hands is amazing in doing that data architecture work. But the reward from having a team do it is actually, turns out it's actually always better. So I'm happy to do what I'm doing now. Actually, I'm one of 4 directors. We've got a large group, about 100 of us or so, depending on how you count. My current scope right now is what we call acute care analytics, and so that's our hospital-based analytics. We have another director who handles population health, which is more ambulatory care, things like that, and another one that handles finance and so forth. I also do a little bit of patient engagement, and because of my background, I'm involved in data warehousing as well, a little bit. So, okay, where do I work? Northwestern Medicine. It's actually Northwestern Medicine itself is actually a brand, and it's which the overarching of Northwestern Rural Healthcare, which is the health system. That's where I actually work, and Five School of Medicine, which is a partnership between the university and the healthcare system. So Northwestern Healthcare. A lot of doctors, we've got a lot of different medical groups, over 200 sites, 10 hospitals. So pretty well known brand. I'm sure most of you have heard of Northwestern Medicine if you have interacted with our healthcare system person. So enough about that. Let's jump into healthcare analytics, and here's what we're going to be talking about today. We all know what analytics is generally. I'm just going to spend a couple minutes though just talking about definitions, so we have kind of a starting point of what we're talking about. Then I'm going to go in for a little bit about what is unique to healthcare analytics. And then this next part, third part, is where I spend most of the time, is how is analytics changing healthcare? And talk mostly about what we're doing in the provider space there. And then I want to talk about the skills that are needed to thrive, to be successful in healthcare analytics. And finally, if we still have time, I want to get into some of the pitfalls that are kind of fun to talk about. So what is analytics? Oxford definition here, I think, is not really too useful. Maybe it makes sense, but Wikipedia one's a little better here, which is analytics, discovery, interpretation, and communication, meaningful patterns of data. I think that's fair. I think that's probably what we all think of as analytics, just in the working definition. But the way I think about it in the context of my job and what I do, this is sort of how I think about it down here. I would break it into the acquisition, preparation, measurement, prediction, and presentation of data, particularly aggregated data. So that's the way I think of it. This is a good working definition. So acquisition is data warehouse, how you bring the data in, and then you also need to build architecture for that. If you're data architecture, so if you're bringing the data in, you got to put it somewhere. Usually there's going to be transformations happening between the source systems and where you're bringing it. And then for data preparation, there's a lot of exploratory work. So just trying to figure out, okay, great, I got maybe one example of something I'm looking at, but then, okay, if I apply those same filters to a larger population, what do I end up with? I'm looking, okay, that really makes sense. Just a lot of work to do that kind of thing. Then also there's data architecture in this piece as well, because there's a different data architecture than the acquisition piece is to build, those are familiar with like a Kimball, facts and dimensions, that kind of, those kind of structures to support reporting. Prepare it, get it ready, do reporting, self-service, all that kind of fun stuff. And then data measurement, working with the business, working with the logic. I don't know, these aren't like totally siloed definitions. There's a little blurriness in here. This is kind of the way I think about it. Data prediction, of course, predictive analytics, machine learning. And then presentation, scorecard, visualization, and exploration tools. Right, so that's what I think of as analytics in the context of what I do, and I think most of the people I talk to who are working in analytics. In healthcare, there's some uniqueness though. It can be complex. I know a lot of things are complex, but there is, particularly in clinical analytics, which is where I'm at, and then really the complexity pretty much stems from just the complexity of the human body, right? What healthcare is treating people, healing people, and there's a lot of science behind that. There's a lot of complexity in human nature, so that drives more complex protocols and decision making within the healthcare industry. And so there's just a lot of complexity there. Also, science is always changing. This is one of the funnest things for me working in healthcare is that what may be considered the right measurement for something one day can change because science is always iterating. We're always learning, getting closer and closer to what the truth is with science. Always getting closer, but never quite getting there. So you never really know anything for sure. But it really makes it fun. I think it makes it change and challenging in a lot of ways too. Another thing, in particular, working with a larger healthcare system, there's a complexity challenge I didn't put on here, but is that all the different hospitals, there's been a lot of consolidation in the healthcare market over the last 10 years or so. And so what we see in a lot of these healthcare systems is each hospital is a little bit independent, kind of acting like its own company in a lot of ways. And so at Northwestern Medicine, we've done a lot of work to try to bring standardization across all of our hospitals, but there still is, you're going to find a little different workflow over here, or a different way of doing something over here. And when you go to try to run numbers on something like that, you're going to find, well, why is this not making sense for hospital X over here? So you get a lot. It's not like if you think of like a Fortune 500 company, so for insurance, I think about something like that. You're pushing kind of down. This is the workflow. This is how we do things. And there's a little bit of both. There's some of that up from on top, saying this is how we want to do things, but there's still a lot of grassroots. This is how we've always done it. This is what works for us. And then there's legitimate differences between these places too. So our flagship hospital, which is Northwestern Memorial Hospital downtown, it's an academic health center. They're residents and things like that. They're the community centers. They're doing more research, more specialized medicine there. So they're just legitimate differences between them. So that just adds a lot of complexity. You're saying, okay, yeah, sure. You might come up with some measurement or some reporting or some predictive analytics for one hospital or one unit in one hospital. But then expanding that out to the whole system, you take a lot of extra work. Also, it's highly regulated. I'm all familiar with personal identifiable information like credit card numbers, things like that. Clearly, there's a level of trust that you expect when you give that information to a company. I think there's financial risk there and everything else, of course, right? With healthcare, your healthcare information may not be a direct financial risk that someone's going to learn about your diseases or what you told your doctor. But there are indirect financial risks, other risks associated with that. It's really important that when we talk to our doctors and clinicians that we can trust that information is not going to get out, because people potentially could make adverse hiring decisions based on knowing your healthcare information, and really, or do you really want your neighbors to know or your family to know everything about you? I think the answer probably is no for most of us, and so there's quite a bit of rigor and regulation around protected health information, so we've got to be very careful with that. So it's something unique to healthcare. Also, there's a lot of measurement reporting that's it's required. It always has been, but it's really been ramping up more and more over the years. Coming from the government, which is really the biggest payer, healthcare payer, Medicare and Medicaid, and then the other healthcare insurance companies that kind of follow along, usually follow what Medicare and Medicaid are doing. And there's a lot of just having to send not just financial metrics on what are your claims or this and that, but actually quality metrics on how well are you performing healthcare, how good are your outcomes, or all of that is a lot of required reporting for that, and we're seeing more and more of that. So those are a couple things that are unique about healthcare. Okay, so this is a fun part of things. How is analytics changing healthcare? I put some thought into this, and I was thinking, a lot of the really fun things that kind of catch your eye are kind of the things I've been reading about, like machine learning to advanced text dictation, a lot like connected, a lot of IoT here, a lot in the IoT space, a lot of interesting things happening with medical devices in hospitals. We're sending out tons of data, and also personal wearables in the healthcare space. That's stuff that I just read about. I don't know that much about. I do read about it. I'm interested in it, but I think you're probably interested more in things that I actually know a little bit more about. And these are some of the things down here. Doing some predictive analytics for things like readmissions, pressure injuries. We'll get into that a little bit more detail. And then using data to do visualization. And then this is really my bread and butter. The thing that I really care about is using measurement and accountability to drive change throughout our organization. It may seem kind of more not as flashy as the Tableau dashboards and some of the other predictive analytics and stuff. But for me, it's amazing to see change in an organization. You can put a good measurement in front of people that need to see it to make decisions. So let's go into some of these. So here are some of the examples of predictive analytics that we've done. Readmissions risk. So if you think when someone leaves the hospital, they probably shouldn't be going back to the hospital right away, right? Or in most cases, I'm sure there's exceptions, but there's a rate that you'd expect to be normal. If you're having too many readmissions, it means kind of why are you sending people home that probably weren't ready, or what's going on there. So this is another one that's reportable to the government and everybody else too. And so we've had quite a bit of success being able to produce a readmission risk score, so that when a nurse manager can get a list in the morning of all the patients on their floor and say, okay, these rank in order of who's the most likely to be readmitted with a score. Maybe there's a threshold to say the score's above so much, we're going to do some special interventions. Because this is where predictive analytics comes in really handy, is when you need to sort a list to focus your limited resources, right? You can't do all the interventions on all the people. There's just not enough resources to do that. So how do we figure out who those folks that are more at risk for readmission? And we've been able to do a pretty cool model of that using our data warehouse for information, but then also kind of reaching back into our electronic health record system for a few more data points that are more recent and pull that into the model and then produce the scores. Another one is pressure injuries, accessibility. Don't recommend doing an image search. I tried to image for that, so I can like what you see. But this is bed sores is the more common name for this. And this is actually a big problem in hospitals. People were sick, they're laying in one spot, various other risk factors. And so we've had quite a bit of success building pretty good models for this. There's an interesting, we came across an interesting pitfall along the way, even though our model was really good. And if time permits, I'll get to that one at the end of the talk. And another one is no-shows. And here's, think about, what we use this for is to say, okay, we have all these appointments, right? But one of the biggest problems in healthcare right now is access to care. There's, Adam, maybe some of you have experienced this where you try to get appointments with some kind of specialist. Like, oh yeah, next available appointment's in 4 months or longer, right? It's difficult, and then there's just difficulty getting all the people in to see all the specialists and other folks that they need to. And so one of the ways that we can try to make it a little better and squeeze a little bit more access to patients out is to say, okay, well, maybe we can figure that there's a high likelihood that 2 of the people in the morning for a particular doctor are not going to show, so maybe we put 1 more person in there. Worst case scenario, they all show up and it maybe stretches out the day a little bit, but it also is going to prevent that situation where you're not utilizing this resource even though there's this huge access problem, right? So it's a balance you got to find, but predictive analytics is kind of helping us with that as well. Data visualization, this is just from Tableau. I just pulled this down in the picture. This is one of the things I can't really show you because if I show you the visualization, you'll actually see the numbers. I have some other reports that I will show with the numbers laid it out. But of course, this is huge. This is a really good way to get people engaged in the analytics work. People get excited when they see, oh, this is the thing I care about. Oh, and look, it's got really great visualizations behind it. And, oh, and better yet, I can play with it and drill down on this. And so this has been a big focus for us. I think over the last few years, we've been kind of moving more of our reporting off of just a sheet of numbers type of reporting into Tableau and other data visualizations. But this is the stuff that I really love. And so this is driving change through measurement. And this is an actual report. Just pull this down. I just write it out on the numbers here. This is our balanced scorecard. And when I started at Northwestern, it's 8 years ago, we didn't have this. We were only 2 hospitals at the time, and we did not have a balanced scorecard of any kind. And one of the balanced scorecards, for those who didn't know, it's having not just financial metrics or not just operational metrics, but having everything in one spot and really figuring out what are the KPIs for our organization. And, this is a pretty finite set. If you had much more of this, I would argue that they're no longer KPIs, they're just PIs, a key if you have too many, because how can you have 40 KPIs be key even though there's too many? You really need to focus in on a set number in order to drive that focus and actually get people to pay attention, right? And so this is one of the coolest things I've ever been part of, because for a couple, it was a technical one, and then the change impact that it had. So the technical architecture behind this is really interesting, because we built a way to separate out writing the measure logic and how those measures then get rolled up and attributed. And a lot of BI systems will work really great if you're just everything rolls up in a pyramid, so this one rolls up here. But if you've got like zigs, you may, for example, I'll give you an example that makes it clear. You may have like a specialty in the hospital, and that rolls up both to the unit or both to like the division, and it also rolls up to a specialty that rolls up with these other hospital specialties, which also they both come back and roll up to the whole total at the end. And doing that, if any of you are familiar with BI solutions, is tricky. And so we built a solution that can handle all that and keep us from having to keep that what we call attribution, which is saying, where does this measure belong? Where does it belong to? Keeping that separate from the measure logic. I could talk for another hour on just that, but it was really fun to do. The other thing that was great is that my boss is now the vice president of analytics at Northwestern. At the time, he was the director. There were really 8 of us back then. And him and the director of our process improvement really pushed this idea with the leaders in our company. And there's a lot of resistance. It took a few years. We got certain pockets were extremely resistant to rolling this out. And now, today, you will see the scorecard at every major meeting. It's how we run our business. It's how, as we've expanded from 2 to now 10 hospitals, how we have kept that vision and keeping everyone on the same page and just driving it. It's been a huge impact. So it's been really fun to be both technically and the impact it's made. This is another example of this is what I really like to talk about, because it's not as big of a thing as the scorecards that we did, the performance scorecards that we're just showing, but it's small, but in a specific area it's really impactful. So this is about this is a GI doctor, gastrointestinal doctors. One physician leader in particular really wanted to get into this measure. They're reading up on the science on risk factors for mortality, which means how many of your patients are going to live or not, for people getting colonoscopies. And it turns out that there's this thing called, I think it's on here somewhere, there's an adenoma detection rate, and that correlates with mortality. So if for example, if a GI doctor sees 100 patients and they should expect a certain number of those to be finding adenomas, which adenomas are I'm not clinical, so that much, it's a lump or some kind of lump or something that they're finding there. So if they're not reaching those rates of the population, then their mortality is going to go up. And they also trace that adenoma detection rate to the withdrawal time from the procedure. So basically, people who are hurrying up and going too fast in the procedures are having less of an adenoma detection rate, and the patients are actually you don't know which one it is, but statistically speaking, patients are mortality, they're not living. People are going to pass away because of that, right? When they otherwise could have found something that was cancerous and saved them, right? So when we put this together, it took a lot of work. It's also really technically difficult because different systems talking to each other, and we had access. And now it's right in front of this is surgeon's days. listed down here. They see their name, they see how they're performing against their peers. There's no better way to get them motivated to make change when they see those numbers and then get that competition with a very competitive group of people, generally speaking, positions. So what that did is the rates went up. It drove the rates up. It drove mortality up, and some folks, I think they may have even left because they couldn't meet the new standards. And so at the end of the day, it's like the closest thing I've done to saying I'm saving lives over here. Because in a way, I'm part of this project that was led to, statistically speaking, lives being saved. Yeah, so let's move on to the skills needed in healthcare. I'll do that time here. So, yeah, there's technical skills, of course, right? All analytics. And in our shop, that means we're a SQL Server shop for the most part. So that's Microsoft SQL Server. So knowing that stack, knowing just how to write SQL really well, knowing the data integration tools. So in that case, it's SQL Server integration services. We also use Tableau. I didn't write here, but also knowing the data model, because the data model we use Epic is our EHR. Knowing the data model behind that is a huge body of knowledge in and of itself. And then the second bullet are things that are like, not everybody knows or has all these skills, but a few people do, and they're really valuable in certain cases. Python, R, those are predictive analytics. C# used mostly for automation of tasks and things like that. Shredding XML, that kind of stuff. PowerShell, same kind of thing. Use that for automation. And then we're starting to get more. This is trying to build better visualization products. So now user design, user experience design skills are starting to become really valuable. And we actually turns out we don't have a lot of that skill set in our department. We have a lot of technical people, really good with data. They write pretty good Tableau reports, but don't have that polish that you get from someone who's a professional in that. And so we have a little bit of that skill, and the little bit we have, we're really leaning on now, and that's something that's important. People relationship skills, I mean, you probably hear this everywhere, really important. We're all working together, right? You have to work with all the people throughout the business to understand what they need. So those are important. Even if you can't work together, this is true, right? You're not going to be able to feel a product if you're not working together as a team. And then this one is the most important thing, but it's also the hardest to figure out, is creative problem-solving skills. This is, I mean, if I somehow knew, if I had two candidates in front of me, one of them if I knew somehow for a fact that this one had great creative problem-solving skills, the other one didn't, but the other one had maybe a lot of experience with all these technical things, I would take the person with the creative problem-solving skills every day of the week. The problem is you can't figure that out necessarily. It's really difficult to figure that out in an interview and things like that. But that is just, there's a lot of just novel problem solving that happens in the space that we're in. There's no manual for how to figure out how to write a complex report, right? You have to go figure it out. You've got trial and error. You've got to do all those things to get the job done. Okay, so this is it's just one slide, but there's actually a lot I can talk about here. It's much time we have. Some interesting things here. So these are pitfalls to avoid in this space. So the first one is taking requirements just as is. And this is like in our shop, we you don't say go get the requirements for the business. We are part of the business. We're all in this together. And that also means that we don't just take, I want these 30 columns and whatever of this population, right? We really want to figure out what problem are you trying to solve. What is it that you really need? And through those conversations, what ends up happening a lot of times is rather than producing some report with 30 columns of data that could take a long time to figure out, to get all that information and validate it. It turns out they just need 3 aggregated numbers or something, right? And they probably want a visualization. They don't want a sheet of a wall of numbers, right? So this is a thing that's actually it's hard. We keep constantly having to train this and remind people about this and wherever. P-hacking is a really interesting one. This comes into play in predictive analytics. So I won't give you statistics lesson here, but the p-value is essentially the p-value in order to make 0.05. It essentially means there's a 0.05% chance that the outcome is due to randomness or but in science, and it's also true of analytics, it's really actually kind of easy to force a 0.05 p-value. Just stop counting data. Like, okay, I'm just going to just keep counting numbers until I get to a p-value and stop. So you have to have your protocol set ahead of time. Know, like, I understand this is what I'm doing before I do it. There's other ways to do that, and that's something I've seen. I've even seen it in the work we do, where someone came out with some numbers that this doesn't make sense. You start looking into how they got there. And yeah, p-hacking, it's a big problem. It's a big problem in science right now too, because there's a publishing bias towards positive outcomes. People don't want to publish negative studies, so there's a big pressure for researchers to get that 0.05 p-value. So it's a problem generally.
What does P stand for? Like, when you say p-value?
Somebody else? It's something to know a little better. I got it every day, statistician.
It's talking about the probability of a statistic being.
Yeah, it's referred to as a p-value.
So what you're trying to say is that it has to be unbiased.
Yes, it's very easy, even unintentionally for people. Just if you don't know how easy it is to get a fake p-value, it's easy to do. So it's a big problem. Yeah, and then there's last thing, I guess, is ethical considerations with predictive analytics. Yeah, you got to be really careful because there's so many different ways this can go wrong. So just if you're training your data on one subset of a population, for example, and then you say, okay, I'm going to apply this to everybody, it may be working great for the people that look like that population, your broader population, but not for others, and so people may not be getting the benefit. Like we've said before, analytics is saying, who's going to get the extra treatment to make sure that one example had, be readmitted? So they're going to get extra care, extra things happening to them to make sure they get readmitted. So you got to be careful you're not. There's no bias in that as well. So. Yeah, I think that's the last slide, but I'm happy to take any questions from anybody.
How do you deal with governance and making sure that your data is accurate? Because it could be anything from anywhere.
Yeah, it's a challenge, right? So I showed you the scorecard before. We have a certain level of rigor we put around those, a lot. Really make sure those are correct. And in fact, I'll go back and show it. These ones here with the NM, these means these are actually incentivized. And so those, I'll keep it within there, those are the ones that will do a lot of validation. And sometimes it's just the grunt work validation of going through and checking examples, making sure it applies in all the different areas across the business. But data quality is a big problem. Also, a lot of the work we do is nurses documenting. So they're documenting something in a chart, and that's also often what I'm working with, our teams are working with. And sometimes they don't document perfectly because guess what? They have to take care of patients, right? So sometimes, sometimes there's a struggle between, you have to report exactly what's in the system versus can we infer what actually happened based on the data we do have? And there's sort of I've had kind of arguments about that, where some people are purists, they're saying, no, this is what's in the system, we're just reporting that, where, I've done things like saying, okay, well, if this thing didn't happen after that we were expecting, we probably can assume that even if it wasn't documented, it happened within a 6-hour period, and you can build assumption-based logic to account for that, because it's not perfect. People aren't documenting everything perfectly, right? And actually, I don't think they should be, because at the end of the day, if you don't want your nurse's most important job to be recording perfect data all the time, you want the thing that to be focused on is taking care of patients. Yes.
Does your team work any qualitative researchers, or does Northwestern use this data to inform deeper? It's obviously quant is great, but a lot of times that's not getting to the deeper social, emotional, or job things underlying in this data, or causation versus correlation.
I'll try to answer, let me know if I don't answer. Can you repeat the question? Yeah, I'm not sure.
Does this, your data that you put out, does that ever inform qualitative or lead to like further deep research with like talking to patients and talking to nurses or to get to like, sometimes you probably see data and you're like, what the heck, what does this mean? Like, you know, you can't really use the quant data necessarily to inform a decision sometimes. Sometimes it needs deeper research.
Yes, the question is, do we use the numbers and the analytics we do, does that ever lead to deeper research? And absolutely, yes. So for one, we have like a quality team in our health system that takes this information and then they'll dive in and people have cases when things come up, just like that. We also have work with a research team that sits on our floor. Even they're mostly part of Northwestern University, and they are doing a lot of more traditional research into things. And so it's both that traditional research and then also like quality initiative research happening with our quality staff. Absolutely.
Can you talk about the managerial journey into putting this scorecard together, basically getting the buy-ins, fighting reluctancies and all of that? You know, I bet when you're seeing things that are looking good, you're kind of biased because you built that yourself
Right.
with your team. You know, I'm right there in my company, and I'd love to, if you can share, you know, any insights for that.
Yeah, it's hard for sure. It was a challenge, and there's still pockets of challenge today. It's a really good question. Part of it is just you got to find your ally, find the allies, figure out who you can convince first, try to figure out where you can make an impact with those people that you can be the first people to use it and champion it, and then you get champions from within your organization too, in the leadership of, in our case, our operational leadership. Once you have a champion or two, that goes a long way. So I think that's just the tactical thing that might be helpful. And then just, making sure that the numbers are actually accurate. At the beginning, it's really important. Like anything could have lost buy-in if for any little thing. So just making sure you're doing a great job and just targeting people. I wouldn't try to run the whole motion and get everyone to buy in at once, but try to find who can be the first people that will buy in and grow that group.
In your experience, at which level is probably the best place to start out for data-driven integration? In terms of, is it at the nursing level where you're looking at management or operations? Is it at the salary level and it's looking at decision making? Is it the finance department for safety of the bills? Is it the C level because they're the ones that make all the decisions? Where do you think is a good place to start, and where do you think is the most successful place to start?
We do all of those, all of the above, right? I guess it depends on the circumstance. So if do all of it, but if you can't do all of it, then why can't you? If you need more resources, then maybe focus on the C-suite. I don't know. So I think it just depends on the circumstances. Where can you drive the most value? Where can you put measurable value that you can show, hey, look, here's what we're doing. I guess that helps.
When you were starting out, where did you see that the biggest measurable value upfront?
So for us when I joined, it was the beginning of the analytics department. But that's sort of unique because there was already people doing financial work. There was already people doing HR and some other things. So really we focused on the clinical analytics when we started off because that was sort of a missing. And there was just a lot of opportunity there in my particular case. Right?
Can you talk a bit about how, I can't really see the scorecard or what the words are, but maybe the process on how those became the key KPIs?
Yeah, so in the beginning we basically, it's sort of a circular process, and leadership informs analytics, which informs leadership. So some of them were just clear, everybody knows, we send out surveys, and likelihood to recommend is like our number one thing. It was always clearly that's going to be honest. So some of them were just obvious, right? And then we said, well, what can we measure? And so we produced just a measures for leadership to choose from. And then they would say, hey, I'd really love to be able to measure this, and maybe we could, but maybe we just require a couple of months of work to get there. And so we let their decisions kind of drive what we pull next.
Where do you pull your data from? Does Northwestern have a centralized data warehouse where patient, treatments and outcomes get stored in, or is it just whatever the nurses enter into Epic and that goes into like some sort of centralized database?
Yeah, so we have over 100 source systems, but my area of clinical analytics is mostly Epic as the source system. And so Epic, in particular, they're a file store, data store. So, but they actually have a relational representation of that data that they call Epic Clarity. It's a relational representation of the file store data that they have. So that's just a starting point. We pull that into our data warehouse. Now they have all these tables and data. And Epic provides tools to figure out, well, where is this coming from, and where is this coming from actually in the system. And so that has everything clinical is in there pretty much. So we take that and then we'll figure out a lot of things and build curated data sets from that. And those new curated data sets will become the base for the next analytics projects and things like that.
To add the question, so is any of the information that you have, the data analytics, is it shared amongst other different healthcare providers, or is it all just centralized in Northwestern and maybe whoever provides insurance to people?
Mostly it's all internal. Some of the aggregated numbers are shared with insurance companies and so forth, and the public even. And then we do participate in these registries. So we put the information in there, and then the registry company may have it, and they share it with other people, but only at aggregated levels, right? So we can do benchmarking across the industry. So there's a little bit of that.
There's a lot of conversation in healthcare about precision medicine. Where's Northwestern on it?
I've heard a little bit about it. It's not really my wheelhouse, so I can't speak to it in depth. I know we're talking about it. I know there's some initiatives on it, and aside from that,
There's a lot of machine learning support for precision medicine. I figured they're talking to you guys.
yeah, no, for sure. I mean, we're not I don't think we're at that point yet where our analytics department is involved in that, getting into the really decision making, that prescriptive analytics and being taking into very personalized medicine and all that. It's an exciting place to be. Maybe we will be in the next 5 years or so. Right now, it's really those technical predictive products I showed. Showed on the slide. So we're not pursuing much of that.
I have a two-part question. Is there a difference between analytics and data science? And the second part is this: how do you, is there a monetary value put on the work that's done there? How do you justify your resistance?
Good questions.